Just have something else on the way to the maximum.
If the store 39. Again. If it is not too much, please call me. So I can approach or hurry when if I want to attend to me. If it's more than 72 hours, sometimes you can just stop.
I will take the phone.
Good evening, everyone. Thank you for joining us today. I just wanted to confirm if our speaker is here today, Dr. Mosala Katan, if she's there.
Hello, Charles. Let me just share my screen.
Thank you so much, Tembi. All right, so I can assume that everyone is able to see the screen. Since able to see the screen, we'll start off. I think I'll hand over to you to introduce yourself. I think we haven't really come up with a formal way of actually introducing this continuous medical education to the audience. But what I can say is that we're trying to embark on an exercise where we'll be trying to educate our members, or rather the doctors who practice within the borders of Botswana, or even internationally, on information that our own local specialists have been able to gather, for them to also share their experiences, to make people aware of their services, and to be able to, interact, given us a chance for people to interact on issues that they've picked up. It may not just be issues related to the disease. It may be administrative issues. It may be suggestions to others. But otherwise, I'd like to extend a warm welcome to our presenter, Dr. Masalaka, who is a pediatric nephrologist. I know that as people join, they do not mute their mics, but we'll try to fix that as they join. But like I was saying, I'd like to extend a very warm welcome to one of our very own, Dr. Mosala Katani, who is a pediatric nephrologist and also a lecturer. She will add, and she's a lecturer at the University of Botswana, Faculty of Medicine. She's here to give us a talk on early detection of kidney disease in children in Botswana. I will hand over to you the podium, and I would just kindly request if you could just state what type of presentation style that you'd be interested in. Do you want to present throughout and then have people ask questions in the end, or do you want to have periodic pauses? So over to you, Naka. Thank you.
Thank you, Charles. I'll just show my face for the ones that don't know this face, and then I will just close that. So I'm Dr. Tembi Msalakatani. I'm a lecturer at the University of Botswana Department of Pediatrics and Adolescents. And I'm also a pediatric nephrology. I offer my services to both private and public institutions. So Charles, I would like to present, and then we can share questions at the end of the presentation. And thank you to Botswana Doctors Union to allow me to come and just share about my experiences so far with regards to pediatric kidney disease, because some of these subspecialties are quite new to the country. And because they are quite new to the country, we're starting to see more of these kids coming in and be referred to us. And some of the diseases that we never thought even existed in our country, we are able to diagnose them and detect them much, much earlier. So thank you, Botswana Doctors Union, for inviting me. So I'm going to start with disclosure. I have no financial gains. Doctors Union is not paying me to come and offer this presentation. And I've also acknowledged the photos and the pictures and the information that I've been sharing here as well. With this, I would like to just start with this picture. I think this picture is a reality of what happens in many homes. And I think we just have to pause and look at this picture, because many of the people here have either seen or have an encounter with a parent who is bringing a child with bedwetting. And I might say that there are some untold impacts of bedwetting in childhood. I've come across the things that I've gotten in the internet. I think one of the things that I've seen during my training was a child in India, in New Delhi in India, a 12-year-old who was bedwetting. And this usually happens in the homes. When a child is bedwetting, the parents are often angry at that child. There is no support for this child. And also the siblings or the family members are also, they're also not really receptive to this child. So we see a 12-year-old who is committing suicide just because he was scolded for bedwetting. There's also in one story that I've also pulled through from Montego Bay, where I train in Jamaica, where a stepmother actually beat this child for bedwetting, and later the child committed suicide. And I also a 10-year-old in Texas, Dallas. What happened was that this child was bedwetting, and as a form of punishment, the parents deprived this child of water for 5 days, and ultimately this child died from this punishment, from severe dehydration. So there is this extreme psychological impact of bedwetting in childhood, and I think we often just brush it and say that it will resolve on its own. And truly, yes, most of the kids who bedwet or with aneurysms will actually resolve. But there is 18% of those children who will continue to bedwet even at adulthood. It's sad to have an adult who is still bedwetting because we never tackled this issue while the child was still, when they were still during their childhood. And also for me as a nephrologist, I'm saying that bedwetting also can be a sign of a kidney or a bladder issue. And if not tackled, we have kids that end up having end-stage kidney disease because of this bedwetting issue that it was never really tackled. So I think this slide talks much, and I hope that we'll remember this slide when we have a child, even at home, or who come to our consultation room because of bedwetting. So I received this child from one of the local pediatrician, Dr. Masikara. It was an 8-year-old female who came to Dr. Masikara because she was sick, and they picked up that this young girl had a UTI. And most of the time when you have a child with a UTI, we always go ahead and do a KUB or a kidney bladder ultrasound. But also you have to dig deep, because you know that at the age of 5 years old, every child should have gained bladder control. So really and truly, we shouldn't expect UTI, or you shouldn't expect anything with bladder issues beyond the age of 5 years old. So when Dr. Masikara dig deeper, he also noted that this child also has daytime as well as nighttime incontinence. When he did a KUB ultrasound, it showed that both kidneys were dilated, and the bladder was able to fill to the capacity of 275. Now, this is a normal bladder capacity for an 8-year-old. But when this child was allowed to empty the bladder, was only able to empty about 92 mils, which means that what was left behind was 182 mils. So it's important that when you send a child to do a KUB ultrasound, you tell the radiographer exactly what you want. You will tell them, I want you to look at all the anatomical structures of the kidney, the ureters, and the bladder. But I also want you to look at it while the bladder is full and also while the bladder is empty, because we are not supposed to leave anything when when we empty our bladder. We can allow a residual volume of 10 mils or less than 10 mils, but when you go beyond 10 mils, we really have to wonder what is going on. Why are you retaining? But you can see that this child was retaining more than 50% of the urine. So Dr. Masigara sent this child to me. So when they come to me with enuresis or incontinence, I usually do a bladder and a stool diary. We call it a poor man's urodynamic study because it actually tells you a lot. It just acts like a bladder, a urodynamic study, but the only difference is that it can't give you the pressures of the bladders, and it also can't give you what's really happening in the walls and the detrusor pressure, but it tells you a lot. So when we did a bladder diary, I noted that this child could be a dysfunctional voider. So what's a dysfunctional voider? So a dysfunctional voider is a child who goes and pees. When she pees, she clamps the sphincter immediately and doesn't empty. She pees and clamps and doesn't completely empty their bladder. And I got even the chance to listen to how this young girl, the parents allowed me to go and listen to how this child was peeing. And you could even hear the stream of the urine. It wasn't a good continuous stream. It was a stream with pauses, with little pauses. So if I was in South Africa where they have Euroflows or urodynamic study, I would have done a urodynamic or Euroflow. And a Euroflow just measures how the stream is and also it gives you a graph, and the graph of a normal stream should be a bell shape like you can see at the top. This doesn't show, but at the bottom you can see that there is a graph, and then there is a pause, a graph. The chart doesn't really go, the chart doesn't really go to the baseline. There's a pause, and then peace, there's a pause. So the child with a dysfunctional voider will have a Euroflow like this. So if I did not do a bladder diary, and if I did not do a KUB ultrasound, I wouldn't have picked up this child. And these kids, if they are continuously having a dysfunctional voider, these kids can end up with end-stage kidney disease. We've seen most of these kids also where I trained coming in needing a kidney biopsy because we did not tackle the dysfunctional voiding part of it. So for me, urinary incontinence is very common. And like I say, for you as a physician or as a doctor looking at a child with urinary incontinence, you have to ask yourself, is this incontinence pathological, or is it something that will clear on its own? So every child with continuous urinary incontinence, that child needs to be referred to me. And I manage these kids with a urologist or a pediatric surgeon most of the time. And this is a child you don't keep with you, because these are the kids that will have end-stage kidney disease if we don't deal with their bladders earlier. And then you have, if it's not continuous, it's going to be intermittent, and you have to ask yourself, is it intermittent only at night, or is it intermittent during the day? If it's during the day, that is pathological, and that child needs to be referred to us much, much earlier. But if it's at night, you have to ask yourself, is it at night only, or is it at night as well as some urinary symptoms? If it's at night only, that is a child that you can try to manage at your consultation room, because these ones are the ones that will most likely to resolve with the urotherapy or some pharmacological intervention that you'll be giving. But the ones that have bedwetting plus some urinary symptoms are least likely to resolve, because it means they might have a pathological aspect of it. So those kids need to be referred to me, and then I will see if they need to be managed together with a urologist or a pediatric surgeon. So if you have decided that this child has intermittent urinary incontinence, and incontinence is only at night, there are things that you have done that you can do. And the first line is using your alarm treatment. So the alarm treatment has very high success rates. And when you use your alarm treatment, the relapse rate is very low. So you can decide to use it alone, or you can decide to use it with a desmopressin. Why a desmopressin? And also, I think it's also important that we don't give everybody a desmopressin. Desmopressin it works very well for those kids who have polyuria at night. And your bladder diary will tell you if this child has polyuria at night. Why? Because with your maturation reflex, you are supposed to have that surge of an antidiuretic hormone at night so that you do not produce enough urine at night and you do not pee. So some of these kids have abnormal surge of the antidiuretic hormone, so they tend to be polyuric at night, and because of that polyuria, then they are peeing at night. So those ones will really respond to the desmopressin as well. And it's important to know that the desmopressin as well, it has side effects. So the one that has really shown to be less side effects and works really well is not the intranasal one. People are moving from the intranasal desmopressin. We are now giving the oral desmopressin, because remember, the side effects is that it causes urinary retention, and these kids can have fluid overload from the desmopressin. And we usually give it at night, and you tell your kids not to drink fluid at night because of that urinary retention. If they drink a lot of fluids at night, they will also have fluid overload. So it's important to know the drugs that you are using and when to use them. And remember, it's not there to cure the enuresis. It is just there to remove the symptoms while you are training this child's bladder not to be able to pee at night. But if your first line and your second line doesn't work, then we can look at the detrusor muscle medication, like your anticholinergics. But at that point, this is a child who really needs to be with us, not at your consultation room. But when the desmopressin has failed, you refer this child to us, because then we have to look for the other causes of nocturnal enuresis, other than, like, we have to exclude the functional or the neurogenic causes. So that was enuresis, and I hope that with that you now are aware that enuresis can be pathological, and these kids can have end-stage kidney disease, and that if you are not winning, you really need to send these kids to us much, much earlier. The other one is the spina bifida. We do have a lot of kids that are born with spina bifida, but when we think of spina bifida, we think of neurosurgery and neurology, but we never think about the bladder issues, and we never think about the kidney issues. So I know also I'm also at fault as well. When I was a resident, I would just say the child had peed, and if the child has peed or the child is moving the limbs, I'm happy, I'm saying the child has no bladder issues. But what we know is every child, almost every child with spina bifida has a neurogenic bladder. You might not see it early, but later on, you will see the effects of the neurogenic bladder with these kids. So there's really no use of repairing that spina bifida if you are not going to refer this child to a urologist and a nephrology, because the thing that is going to kill them is going to be your recurrent UTIs from that neurogenic bladder. So this was a study that was done in France. It was a multi-center study. They looked at about more than 8,000 children with spina bifida. And you can see the #1 cause of death was urological disorders and its neurogenic bladder. The second leading cause was pulmonary disorders. And then you can see that neurological disorders was the third leading cause of death in these kids. So I hope from here, you know that when you see a child with spina bifida, wherever they are, because there are so many, you have to think about this presentation and refer these kids to us. We have a very nice working relationship with Dr. Mutloboga. She was presenting last week, and we treat this child together as a team, and we've introduced clean intermittent catheterization. And the parents, believe me, the parents really do well, and they have learned, they know how to catheterize these kids to empty their bladders. So in the Western communities, as well as in Cape Town where I train, when a child is born with a spina bifida, before they go home, even if they are doing well, they are passing urine, you have to have done a creatinine, you have to have done a KUB ultrasound before you discharge them. And those centers have a very good spina bifida clinic, and before they go home, because we know that all of them will have a neurogenic bladder, they are already taught how to do CIC, which is the clean intermittent catheterization. And the parents are really comfortable with doing that and also emptying the bowel, because we know that the bladder and the bowel, they are in close proximity. If you don't deal with one, the other one won't be repaired. So for me, especially in private facilities, because unfortunately in our public facilities, we are trying, but in private facilities where the resources are allowing, I would suggest that you should not send a child home without doing all these things. And you can send them to us because, like I said, we've already started this we're already working with the stoma people to be able for these parents to be taught how to do a CIC. I know the first time when we tried to introduce the CIC with Dr. Mutloboga, to the parents, the sisters, the nurses were really not comfortable with allowing these parents to go home. But the parents are coming back to us. Their kids are no longer, they don't have to use diapers. Their kids are dry most of the time, and they're not sick all the time because of a UTI. So I did this study as part of my MPhil. And I looked at, because Cape Town has a very good urodynamic facility in South Africa. So I looked at all their urodynamic studies for the kids with most importantly with neurogenic bladders. And these are the kids that have done ultrasound. These are the kids that have done MCUGs. These are the kids that are already on treatment, and they are coming for urodynamic studies. And we noted that the majority of these kids, their bladders were abnormal despite having all these treatments of Botox, of augmentation. So the urodynamic, knowing the urodynamic studies of these kids actually improved the outcome, because you know exactly where to target, if you are targeting the detrusor pressures or if you are targeting the sphincter as well. So this is something that we really need in Botswana, because it can improve the outcomes of children with incontinence as overall. And then the third thing that I would like to talk about that I've also seen and have an experience with that, with the congenital abnormalities of the kidneys, ureters, urinary tract system in Botswana, is the late diagnosis. In first world countries, they have a good fetal anomaly screening program. And I think in our facilities, the only people who are able to pick up anomalies during pregnancies are the ones that are in private, because they are able to do 2 scans. They are able to do the scan in the first trimester, and they are able to do the anomaly scans. But in our government system, where we are oversaturated, resources are limited, these kids actually present late, and it's very sad to see these kids struggling and now coming in, because if you leave Kakut without treating it, some of these kids lose their kidneys and they need dialysis much earlier. And I must thank a lot of doctors in Maung, because especially Dr. Mandisa, she's been able to pick up so many of these kids that have been missed before, and now they are coming in and we are able to treat them before they go back to their facilities. This is a case that we saw in Marina. It's a day 2 of life who they call me because this child got sick on day 2 of life, showing signs of sepsis, which was urosepsis. And then when they did the urea, when they did a screen, including their urea and creatinine, the urea was 28 and the creatinine was 492 in a day 2 of life. So you wonder, this is a child who had unremarkable delivery. So we're not thinking birth asphyxia on day 1 was fine. So why would this child have such a high creatinine on day 2 of life? So they went ahead and did a KUB ultrasound. And from the ultrasound, they said they could not visualize the right kidney, but also the left kidney, there was poor cortical medullary differentiation. So we were really worried about caput. And with consultation with the radiologist, we opted to do an MRI of the abdomen and the MRI of the urethral system. And they noted that the right kidney was not there at all. And the left kidney was very small. It was about 1.5 to 1.4. And this is what we usually do when I have to measure your kidneys. I have to plot them here to see if they are appropriate for age. And when a child is born, their kidneys should measure between 4.5 to 5 centimeter. But you can see that this kidney was only 1.5. No right kidney and only 1.5. So this is a child that we don't expect to live long without any intervention, and the intervention will be a kidney transplant. Unfortunately, this is not what we are able to offer in Botswana, especially even in other first world countries. We only do kidney transplant when the kids are beyond 10 years, 10 kg. So it means it will take a very long time for this child to gain 10 kg and to be able to get a kidney transplant. But because they have agenesis and dysplasia, sometimes they pass high amount of urine and they can take quite a long time to get to end stage where the kidneys cannot function at all and they need dialysis. So if we were able to do an antenatal sauna, we would have picked up that this child didn't have kidneys and would have been able to advise the mom accordingly so that this mom is not shocked. And it was a teenage mom. And so that we prepare her very well in time about what she should expect with her child. And this one was from Maung, from Gumare. It's a 2-week-old where the mom just came because she said my child was constipated. And when Dr. Kisuteng examined this child, she noted that there was a very large mass that was almost crossing the midline. When you ask the parents if they were not able to see this mass because the abdomen was markedly, you'll be surprised. The parents would think that is normal and constipation was the abnormal thing, and it happens, unfortunately. So Dr. Kisuteng did an ultrasound and noted that there was this large cystic mass of the right kidney and also of the left kidney, and couldn't really visualize the other kidney. So he sent the child over to us to do further investigation. Because we were not quite sure in terms of the ultrasound findings, we decided to do a CT abdomen, and the CT abdomen just showed that this was actually hydronephrosis and of the right kidney, sorry. And when you have a child like this, we do have nuclear medicine in Bokamoso, and you have to do a MEC3. Because you can see this kidney is nice, on the right kidney is there, it's very small, and you can see this huge dark thing, which is the kidney, and you can see little or no tissue of the kidneys. So when we did a MEC3, the MEC3 will tell you if this is an obstruction or not an obstruction. Is a very good tool, but it also tells you about the function of that kidney, and it was only functioning 8%. We expected 50 to 50% in a normal kidneys, but this kidney was only functioning 8%. So we did an MCUG also just to make sure that there is no obstruction below that could have caused this obstruction, and there's no VUR as well. We have all these facilities in Botswana, so we can really diagnose all these kids in Botswana. So this child I sent to the surgeons in Sidilega at that time because we didn't have a surgeon here, and she just diverted the urine, and so that she can now plan for further for nephrectomy because this kidney was functioning. But later on we had a debate, because these kids we have to debate, is removing the kidney okay, or could we just leave it, because at that point it wasn't causing. So we sat down when Dr. Motlobogo came, and we decided that since it was not causing any problem and we're able to compress and divert and child and see, and if it is that in the future it causes problems, then we will take out that kidney because it's actually non-functional. And sometimes if we pick them early and there was small tissues, those kidneys, if you resolve the obstruction at the PUJ junction, the function can improve from 8% to even 25%, and the child can live normally. And then these are kids, we have so many of these kids in Botswana. I did not know this. And some of these kids, it's sad because we are picking them very late and the parents have been struggling. Some of these kids can just present with failure to thrive. Like we have one who is from Nyangagwe, who have been seen for the past 3 years, being followed up also by the dietitian, because this child was not picking up, and the mom says, I was feeding. She's also a teenage mom, but she's very vocal, and she will tell you that I was feeding this child, but this child was just not gaining weight. And yes, there was something with the urine as well. So for me, I said kids with the posterior urethral valves need to be followed up by me, the nephrologist, and they also need to be followed up by the ped surgeon or a urologist, in our case, a ped surgeon in our facility as well. So I'm gonna share a case, but we do have a lot of kids. I was attending this conference to say that the posterior urethra, there's a genetic component to the posterior urethral valves, and I do believe that in our setting there must be some genetic problem going on, because there are so many and they have been missed. So, but this one I saw in Cape Town, and it's similar to what we are having here. So this child presented at the age of 8 weeks with urosepsis. Now, Cape Town, they do antenatal sonars, and majority of them, they are picked up while they are still in utero, and they are dealt with earlier on before they go home. So at 8 weeks came in urosepsis, they did an antenatal, so they did a sonar and an MCUV, which confirmed that this child has posterior urethral valves. You can see the ureters are dilated, the bladder is thickened, and there is also some debris in the bladder, which shows that there was an infection. And when you do an MCUG, you can see that constriction just after the neck of the bladder. And this child, they ablated the posterior urethral valves. They do usually ablate twice within a period of 6 weeks. And then, because this bladder was just so damaged, they did a vasectomy as well, so that they can just protect those kidneys from end stage. But after those procedures, the mom was lost to follow up. But when she came to us at the age of 11 years, she was telling us that since the operation was done and the child was passing urine, she thought the child was healed. And this is not a mother who would lose follow-up, because she had a child with Wilms tumor and she was coming to clinic for that child. It was only this child that she thought, because all these surgical procedures were done, everything was sorted. But at the 11 years, the child came in with end-stage kidney disease. Why do they have end-stage kidney disease? They do have end-stage kidney disease because in utero, while the problems are happening, the bladder is already damaged. Even when you relieve the obstruction, remember the child goes through a series of events which we call the valve bladder syndrome, where they have this high pressure bladder, And because they have this high pressure bladder, they then have myogenic failure and they have a floppy bladder with urinary retention. And because of that urinary retention, which behaves like a neurogenic bladder, their kidneys are always getting infections, their kidneys are scarring, and later on now they develop end-stage kidney disease. That is why a child with posterior urethral valves need to be followed by a nephrologist, not just the surgeon, but also by a nephrologist. Apart from the valve bladder syndrome, they also have metabolic complications. They have RTA, they have polyuria, they have chronic hyponatremia that are failing to thrive. The child who came from Nyangago 2 weeks dietitian was actually a posterior urethral valve that we had missed for the past 3 years, and now the bladder is so damaged. It has this what you call, I'll remember the words, but they also get this recurrent urinary retention, infections because of retention. They get aneurysms and they develop end-stage kidney disease. So please, if you see a child with I get a lot of people, because sometimes the urologists will say they don't see pediatric patients, which is rightfully so. That's why Dr. Motloboha was saying the urological issues in pediatrics that are followed up by a ped surgeon. So we cannot force the adult urologists to see, especially the younger ones, but we know that the nephrologist also plays the biggest role in these patients as well. So for me, the take home is that we really need to strengthen our fetal anomaly screening. I know there are a lot of OBGY people here, they can advocate for that. And also remember that kids with CACUD are managed through a multidisciplinary team, and the nephrologists and the urologists and the ped surgeons are at the forefront. Nobody is being left behind when you are managing these kids, because you manage the other things, but if you forget about the other complications, there is no use. And then this is another sad story. I'm sorry, I'm going to say a little bit of sad story, but sad stories are there to teach us so that it doesn't repeat itself. So I have a 15-year-old who is currently receiving dialysis at Renal Care Institute. Dr. Salishando has been following up this child, but this child has primary hyperoxaluria and is the cause of the end-stage kidney disease. The mom, when you hear the story, the mom says, my child came at the age of 6 years and was diagnosed with kidney stones, and the kidney stones were removed, and she was given the kidney stones to go home with. But all was well, the child was doing well, but 4 years later, the child came in with end-stage kidney disease. Because we did not have a nephrologist in the country, this child was rushed to South Africa. When the child got to South Africa, they did a KUV that showed multiple calcifications with very small kidneys. And then they spoke to the mom that we think this could be due to some metabolic disorders that causes kidney stones. And the mom says, you know what, I have some kidney stones with me that were given to me 4 years back. And the doctor said, can you bring them? She had them with her so that we can go and test them. And when they tested the child, everything was in keeping with hyperoxaluria, most likely primary hyperoxaluria, which was the reason for the cause of the end-stage kidney disease. Now, this child has been on dialysis for 5 years. She needs a kidney and she needs a liver transplant. And because at the moment we are doing only living-related donors, there is nobody in the family who is fit enough or who is ready to give out a kidney, or who is sometimes somebody who is going to give a kidney, and because if you don't do both of them, there is no use. Now, why did this happen? This happened because we did not do a metabolic workup for the kidney stones. So every child, especially pediatric patients, for the adults maybe, but for the pediatric patient, kidney stones are very rare. So the majority of the kidney stones are usually due to a metabolic problem. So every child that has a kidney problems or that has nephrocalcinosis, you have to do a metabolic workup, and you have to refer to a nephrologist even after removing that kidney, that child needs to come to us because we'll deal with the medical aspect of the kidney stones. I have another child who is 4 years old, who is on dialysis, also has primary hyperoxaluria, which was the cause of the end-stage kidney disease. And luckily, this one we were able to do genetic testing, and it was positive. And this child was coming from Good Hope, presented as a crash lender as well. And he is waiting for the kidney and liver transplant. When you look at the internet, they will tell you that primary hyperoxaluria is very rare, it's a rare disease. But we do have these kids in Botswana that have this rare disease. So because we are not screening much, we might be missing many of these kids. So my take home is that please, when you have a child with kidney stones or a family of people with kidney stones, they need to be screened for metabolic causes of kidney stones. And there are certain things that we do in the serum, there are certain things that we do in the urine to analyze the urine, to analyze the serum. The similar things that we are analyzing in the urine and in the serum, if you are able to get the kidney stone itself, you have to analyze that kidney stone for those certain things that I've listed there. Now, the ultrasound, the high resolution ultrasound, it's very good in picking up kidney stones, even though sometimes it can miss out the very little ones or the ones that are in the ureters. But the majority of the stones, you can pick them up using the ultrasound. If you feel like you are missing some, you can do a CT scan, but we are able to just doing an ultrasound. I never did a CT scan for the 4-year-old. The ultrasound was able to tell me that this child has nephrocalcinosis. And then I just went ahead and did a metabolic screen, and the metabolic screen showed that this child had primary hyperoxaluria. So please remember, metabolic workup for kidney stones or for any family members, just dig deep, and so that we can pick up these kids much earlier and prevent end-stage kidney disease, because we can prevent end-stage kidney disease because some of them can get a liver transplant before the kidney gets damaged. And some of them, we can even give them some medication so that we can protect the kidneys. The other thing is hypertension. Next week, it will be the World Hypertension Day. And everybody, when I talk about hypertension, they think that hypertension does not affect kids. Hypertension does affect kids, and it's really increasing at a higher rate because our lifestyle. So we see the primary hypertension going up because now we have this season of obesity. So because of that, we do have many kids with primary hypertension. But all in all, you should know that hypertension in children many of them is due to a secondary cause, unlike in adults. So I had an 11-year-old male, was from Kasane, and then was being treated at Nyangagwe. She presented with seizures, and when they did a physical examination, it was significant of very high systolic blood pressures of 180 and 200. So they were worried about a hypertensive emergency, and they did a CT scan that showed that that area of hypodensity in the occipital region. So because when you see hypertension with this type of a CT scan, you have to be worried about press. So we did an MRI at Sidileha when the child came to us, and it did show that it was press. But while was at Nyangagwe, because of this hypertension, and they know that hypertension in kids is usually secondary, they did a KUB ultrasound that showed that there was a small left kidney, and that kidney had a kidney stone with hydronephrosis, hydroneuritis. They sent the child to Sidileha. They were able to remove that kidney stone, and they wanted to do a nephrectomy, but they wanted the hypertension to settle, and the child was sent home. Came again with the hypertensive emergencies because the parents also were lost to follow up. And at that time now there was a pediatric nephrologist, so child came to us, we did an MRU just to make sure that we are not missing anything. Even the cardiac cath, there is cardiac catheterization that is done by our pediatric by our pediatric cardiologist. It's been done at Sidilera. So we are able to see that even the left renal artery was not functioning. This child had non-functioning left kidney. Even that left renal artery was non-functioning. So what we did, the only thing, remember I told you that when the kidney is not functioning and is causing problem, it has to be taken out. So we sent to our ped surgeon there in Sidilera. They did a left nephrectomy and they did the analysis of the kidney, which showed that it had severe nephrosclerosis because of that severe hypertension as well. So ever since taking out that non-functioning left kidney, the hypertensions have resolved. I've been in communication with the doctors in Kasane. The child who was on 5 antihypertensives is now on nil antihypertensives since September and has been doing so well since then. So a non-functioning kidney that is causing problem needs to be taken out, and hypertension in pediatrics is most likely due to a secondary cause. And if we don't check hypertension, we are going to miss it. Another one, this one, and I saw in private, develop a stroke. It was sent to me by our neurologist develop a stroke. And when they did an MRI at Nyangagwe in Riverside Clinic, they noted that there was a hyperacute density in the gangliocapsular region, and it was in keeping with a hypertensive stroke. When they looked at this child, was having a history of headaches as well. But the funny thing about this child is that every time there was only one incident when he presented that the hypertension was elevated, but not severely elevated like that one. It was in the 140s. But now this child has the imaging that is in keeping with a hypertensive stroke, but every time we see this child, the hypertension, the BP is normal. So I asked the neurologist consulted me, and we did. This child had nocturnal hypertension. At night, this child's BP shoots up. And also when you analyze this, there was poor nocturnal deep. This child had masked hypertension. If we didn't dig deep enough and just left it like that, we would have missed hypertension in this kid. Nocturnal hypertension. There have been studies where kids have nocturnal hypertension of unknown cause. So we treated this child, even though the parents were not keen on treatment, but because this child had stroke before, there was no other way but to treat this child, but it was masked hypertension. So the guidelines that we should be using is that every child, when you see that child, if you are seeing a child, you should have a BP curve, a pediatric BP curve. And when they come to your consultation room, you should do the BP. You should check their BP. Any child who is high risk meaning a child who was born prematurely, a child who is obese, a child with family history of hypertension, those ones also should be screened. And if you suspect hypertension, you have to do a 24-hour ambulatory BP at some point. It doesn't have to be at diagnosis, but at some point, we have to do a 24-hour ambulatory BP machine. I know we are seeing a 24-hour ambulatory BP machine in our WhatsApp group. And I must say the guidelines, both adults and peds, we are moving towards the 24-hour ambulatory BP as a means of diagnosis at any point, because we don't want to miss masked hypertension and the child presents with a stroke like that one. The diagnosis of hypertension, I'm not going to go too much. Number one, you have to confirm that indeed is hypertension, and then you have to investigate for the secondary cause. Hypertension in any child, you have to get a KUB ultrasound. Do not leave a child with hypertension without doing a KUB ultrasound. Because 80% of them, hypertension is due to a kidney cause. All right. And then when you see them, you have to now see if there is any damage, target organ damage. You check the eyes, cardiac, and then renal as well. And I was attending the adult presentation in the mornings, in their morning meetings. They were talking about first line and second line. For peace, there's no first line and second line. we treat according to the cause, because the cause is usually secondary. So if it's fluid overload, I'm going to use Lasix. If it's a renal artery stenosis, I'm going to avoid the ACE inhibitors. If I think it's due to a pheochromocytoma, I'm going to use an alpha blocker. So it just depends on the cause. There is no first line or second line in our pediatric patients. The other one, which is, I think, is the second from last, is a kid who comes in with recurrent edema. So most of our kids that I see with end-stage kidney disease or with a chronic kidney disease, they have been to our clinics several times with recurrent swelling of either the eyes or other extremities, and they have been labeled as allergies until when it's too late, then somebody comes in and does a urine dipsticks, and now it's they diagnose a nephrotic syndrome. So my teaching is that every child who comes in with recurrent edema, even if you are taking your history and you think it's asthma, please just do a urine dipstick. It doesn't cost much, and check if this child is losing proteins from the kidneys, just to make sure that you are not missing a kidney disease in this kid. We have a whole lot of them. So this is a study that we did at Princess Marina when I was still doing my MMed. We looked at 28 kids who were diagnosed of nephrotic syndrome, and the one surprising thing is that about 40% of them had familial nephrotic syndrome, meaning that they had nephrotic syndrome, a sibling had a nephrotic syndrome, and another sibling had a nephrotic syndrome. There was nephrotic syndrome in the family. So that is worrying for us, because we know familial nephrotic syndrome is very hard to treat, and it's very rare. So the other thing that also was surprising is that these kids have been to the hospital, to the clinic before presenting with edema. And when they came to us, 90% of them had severe low serum albumin, because they've been all over before. It was now overwhelming. Because all nephrotic syndrome depend not, irrespective of their diagnosis, all of them have to get steroids. So we gave them steroids, and 18 out of 28 did not respond to the steroids. That's close to 70% were steroid-resistant nephrotic syndrome. And the 8 that we did not know if they responded or not, they were lost to follow-up. So it means that it could mean that also they were steroid-resistant nephrotic syndrome and just lost to follow-up. And we did a kidney biopsy, because if you have steroid-resistant nephrotic syndrome, it's a problem for us as pediatric nephrologists, because those are a nightmare to treat, and there's really no treatment for steroid-resistant nephrotic syndrome. They often end in end-stage kidney disease. So those are the ones that need a kidney biopsy. We did a kidney biopsies, and all the 18 of them, and all of them had FSGS, had focal segmental glomerular sclerosis. So why is this not a good thing to have? It's not a good thing to have because I'm missing a slide, because the focal segmental glomerular sclerosis is actually very hard to treat. We do not know. There have been studies every year, everywhere, trying to figure out how do we manage focal segmental glomerular sclerosis. There is no treatment, and often they progress to end-stage kidney disease within 2 to 4 years of their diagnosis. One of our NMED registrar is looking at these kids to see how long they take to reach end-stage kidney disease. It will be interesting to find how long. And these numbers are much higher than what we see internationally. And we know that the majority of them, the cause is actually genetic, and we can't do genetic studies in Botswana. We've only been able to do one genetic testing because the child needed transplant, and it was positive. So it means we are missing a lot of kids with genetic FSGS, and we are giving them all these medications that are not going to help. And we are even leading them to end stage, because some of these medications are nephrotoxic that we give them. So they usually don't get any treatment. We just treat supportively for these kids. So this is a big problem for us. So my advice here is that every child that has nephrotic syndrome, please be vigilant. And for me, for Botswana, usually this is a treatment that a pediatrician can do. But for Botswana, based on our statistic, I would say this kid needs to be referred to me much, much earlier so that we follow them closely, because we are losing so many kids with steroid-resistant FSGS. My clinic has over 60 of them, and there are some in Nyangawa, some in other areas of Botswana that are being followed up with consultation with me. So we are really missing these kids, and we are diagnosing them early. So I usually get calls to say that I have child with edema who has 1+ proteinuria. Remember, nephrotic syndrome, you have massive loss of proteins. So 1+ proteinuria is not suggestive of nephrotic syndrome, but because sometimes we keep our urine dipstick open, they are damaged. I always tell them that before we say it's not nephrotic syndrome, it's something else, let's just do a urine PCR to quantify. And if it's an older patient, we do a 24-hour urine collection to quantify before we can exclude them. But you really have to have a high protein loss, 3+ or 4+, for it to be a nephrotic syndrome. And other things that are additional to high nephrotic range proteinuria are low albumin and or edema. So if you have either of those things with nephrotic range proteinuria, that's a diagnosis of nephrotic syndrome, and these kids need to be followed up by me as well. And this is what I just said about nephrotic syndrome, FSGS, that they are nightmare to us. And remember, even if we transplant these kids with FSGS, they can recur on the table during transplant on a new kidney. So they can recur right there and there. So even the transplant is very special, the way we treat them during transplant, because we know that we can lose the new kidney within seconds like that. The other thing is unexplained fevers. Kids with come with unexplained fever, please do a urine dipstick, because you might be missing a urinary tract infection. So this is a child that came in with urosepsis and on the background history of unexplained fever. Because it was a UTI, and we did a KUB ultrasound that shows bilateral hydronephrosis and hydrouretas, and this child had high-grade vesicourethral reflux, which could be primary, but you also have to rule out the secondary causes of the high-grade VUR. So most of these kids, they will say, this child has been having fevers, we've been doing TB workup, we couldn't find anything, we've been doing this, but we always forget the kidneys and the urine dipsticks, and these kids can just present with a UTI. So unexplained fevers, remember, it could be a sign of a renal issue in these kids. And a high-grade VUR lead to renal scarring and end-stage kidney disease as well. So for me, there are several guidelines that we use there. But for me, for Botswana, I say every child that has a UTI below the age of 5 years, they should get a KUB ultrasound to rule out any renal issues, because you don't want to miss those renal issues and the child coming in with end-stage kidney disease. The other things like your VCUG or your MEC3 or DMSA will be guided by what you found on the renal ultrasound. For some guidelines, like the Americans, they use the NICE guidelines, and the Indian ones, they only say the child if the child is less than 2 years. But for me, I say in Botswana, if they are less than 5 years, because we might have missed these kids before. This might not be their first UTI, it might have been recurrent UTI and we have missed it. So do a KUB in all of them. And if you find something, send them to us. So that was my last, just to share some things that we see, that we've been seeing so far, but we have so many of them. And I just want to thank the ones that have been referring the patients. We've been getting some of the patients much, much earlier. But my summary is that, remember, chronic kidney disease is not rare in kids, it's there. And the kids they present very late. They come to me as crash landers. Crash landers meaning that they come to me already requiring dialysis. right? So we do want to pick them up before they require dialysis. And just know that if we detect them early, we can prevent this devastating effects of chronic kidney disease, which is devastating for the child, which is devastating for the parents as well. This child at the age of 4 years who is dialyzing at GPH, the mom has to be moved from Good Hope every morning on Mondays, Tuesdays, Wednesday, and Friday for dialysis. But because it's primary hyperoxaluria, she should be dialyzing every day, but we are just compromising. So it is devastating for the whole family and for the nation as a whole. With that being said, thank you everybody for listening, and I hope that we can detect these kids earlier. And these are my sources. I'll just want to say thank you to Jeanette. She runs the urodynamic studies at Red Cross. I've used some of her slides, and I've used also the Evelina London. I follow them very closely. They're great mentors at the Great Ormond Street for urodynamic studies. That's my area of also of speciality for urodynamic studies as well. So I've used some of their slides. And if you want to refer a patient, I do, by virtue of me being a lecturer at UB, I do run a clinic at Princess Marina Hospital. But for the private patients, please send them to Gaborone Private Hospital, because we want to relieve those who cannot pay or who don't have the means to seek private care for Marina. And those who have money to pay, they can go, so that we can reserve the resources for the ones that can not pay. So those are my contacts if you want to get hold and refer these patients. And thank you everybody for listening. Over to you, Dr. Charles.
No, thank you so much, Naka, for that powerful and brilliant presentation. I think we all can see how knowledgeable, but also how noble you are, and the contributions you're making towards improving the healthcare system. I hope the doctors and medical students in this platform are noting your presence, noting your presence in the sense that there is now that facility for referral, and we're taking down the numbers that are currently being projected on the screen. I think maybe the question I had before I jump into the audience was just to ask if people want to consult with you on a case, especially those who are in government. We do have a lot of doctors who are currently based in the outskirts, the DHMTs, you know, with Charles Hill, what. Are they able to contact you? Are they able to speak to you to consult with you, or how is it for now? I don't know if that question makes any sense.
Yeah. Thanks, Charles. Yeah, I think for me, my phone is open. I'm happy to get, even if it's at night, because I've been working in Mahalape. I know how sometimes it's very difficult to have a child in front of you and nobody can help you. So that's why I always leave my phone to the doctors. They can consult me at any time. So for those in the Doctors Union chat, my private number is there as well. It's 72858561. So you can just consult me if you need any clarification or you need assistance just on pediatric nephrology or urology cases, or just pediatric patients.
No, thank you so much for that. Clearly we can see that you are a BDU member. But anyway, so I will be jumping into the comments that are currently in the chat. I think if this was a physical lecture, we would have a standing ovation. It's called ovation. But for now, we have a lot of people just thanking you for such a brilliant presentation. I did see some reactions from the virtual room in the form of hands. So I see a comment. The first one is a comment. I'd like to ask if Dr. Morekisi is still there. I would like to ask if Dr. Morekisi can just unmute his mic and then just verbally say what he has typed in the group just for our own appreciation. I don't think I'll be able to articulate it the same way he has typed it. So Dr. Morekisi, if you can just unmute your mic and then read out your comment, that will be very much appreciated, sir. Thank you.
Dumelang. Yeah, Naken Kitso Marekisi, one of the urologists based in South Africa, but ke Botswana. So with the issue of PUJ obstruction, if a patient comes in the first time and you are waking the patient up, you can start with a KUB ultrasound to determine whether it's bilateral or not, because it will assist in whether you manage it urgently or not. But if you find that it's unilateral UPJO, then you can confirm it by doing a MEG3. But if your MEG3 shows that the differential count or your DMSA is less than 90-10%, then you have to divert the urine or create a channel for empty in the UPJ. So what you need to do is either try to stent the patient using a DJ stent. If you are unable to, then you can do a percutaneous nephrostomy, then allow the system to decompress, then repeat the DMSA scan, because you want to identify if whether you are dealing with a non-functioning kidney or not, because if you repeat your DMSA scan and it shows that there is an element of function, then you need to give that kidney a chance by doing pyeloplasty. If then the child over time develops recurrent infections, develops renal stones, or even intractable pain, then you'd be nephrectomy. But up until certain steps are met, then it's not in the best interest of the patient to move straight to a nephrectomy. That's something that I wanted to just clarify. And also, before the nephrectomy, the most important thing is to do a voiding cysto urethrogram to check if there is reflux in the same setting, because if you are going to do nephrectomy, then you have to include the ureterectomy in the same setting, so that you make sure that the reflux doesn't end up bringing the child, introducing infections to the child. And because the child, if there's a ureteric stump that is left, then what's going to happen is that the child will present with recurrent UTIs. So those are some of the things that we have to look at in terms of how we manage a child who presents with PUJ obstruction. So it's always allow the system to settle by diverting the urine, then repeating your DMSA scan to tell you whether there is improvement in the function of the kidney. If there is no improvement, then you can go ahead with the nephrectomy, provided you have done a VCUG to rule out reflux. Because if there is no reflux, you can leave the stump. But if there is reflux, you need to also remove the ureteric stump. But anyway, it was such a wonderful presentation. I learned a lot from it. Thank you.
Thank you so much. Oh, sorry.
Yeah, I was gonna say I wish Dr. Mogitsi could see me, because I was smiling throughout when you were explaining, because I think it's very nice to see that we have a lot of specialists now coming, Botswana specialists coming, and we can discuss this and give our patients the best care. So thank you, Dr. Mogitsi. I was smiling when we were talking.
No, thank you. Then we have a hand from the floor. Kutlo has a hand. I'll just ask her if she can just unmute her mic and ask her question.
I think mine are more comments than questions. Thank you very much, Dr. Msalakatani, for a very good presentation. And I think maybe we need, let me just clarify, because I think Peter's comment is coming in from that patient with the PUJ obstruction. So I think maybe I need to clarify for him what was different about this particular case. And I definitely agree that we should not be thinking of nephrectomy as a management plan for our patient. But I think what is unique about this case anyway was that one, this patient had a multicystic dysplastic kidney. So we knew before the diversion was done that this was a non-functional kidney. Two, the diversion that was done, because I'm seeing this child months later after the diversion is done. The diversion that was done had completely closed off months in advance. And I think the repeat ultrasound has shown evolution of that multicystic dysplastic kidney. So that's why at this particular patient, there was no need to do any further surgery because of obviously the limitations. And as someone who works in Botswana in the government system, there is significant limitations into what care we can offer because of the resources we have. We obviously don't have a DMSA scan. If you need one, the parents would either be able to afford to go to private or, you know, there will be some way of motivating to get them done to private, which is, again, as we understand, not an easy thing to get done. So we also can't get a repeat DSMA scan as frequently as you would need to get it done because of the resources we're working with. So, so that's why sometimes you can't follow the protocols the way you're supposed to practice because of the limitation. The other thing is we did not have fluoroscopy. So you also can't repeat an MCG as frequently as you want because traditionally we've been sending these patients to private and the private system is limited. So there's a lot of challenges in managing kids with kidney disease. But I think I would thank you, Dr. Mosalaka-Tane. You're doing a very good job, not only in picking them up, but making sure that as the referral facilities are bringing them to you, you escalate the care as necessary. But I think the spina bifida one, just as a last comment to your presentation is, I think in my opinion, one of the worst ones we see with renal failure. So yeah, I think just as a comment to everyone that these patients would have some element of dysfunction of the bladder, and eventually some of them develop kidney failure. So not that everything else you didn't say was important, but I think those particular group of patients are the ones that we see with the worst end of complications. When they come to us, they really are in a very bad state. But thank you very much. Really appreciate it.
Thank you, Kuto.
Thank you so much, Kuto, for that brilliant comments. Is there any other comments or questions from the floor? Okay. I think that's just how brilliant the presentation is and how high level it is. There isn't any questions, but I think I can speak for all of us, Tembi, just to say that this was a very brilliant presentation. And we really learned a lot, and I can see, or we can see, where our healthcare system is going. I see there's another comment in the chat. The comment goes as, there seems to be an epidemic of constipation out in the pediatric population. Any word on avoiding dysfunctional and constipation?
Yeah. Thanks, Dr. Steady. So there is this syndrome that we call bladder bowel syndrome, and it's coming from the fact that the embryology as well as the anatomical location of the two, of the bowel and the bladder, they are in close proximity and close relationship. So during the presentation, I had said that if you treat the bladder, make sure you treat the bowel, because if you don't treat the bowel from the chronic constipation can cause incontinence or UTI. So you always have to make sure that when a child comes in with the bladder issues, you have excluded constipation. And there is an epidemic because our kids, their eating habits, also they are sitting down, playing on the internet. So there's a lot of constipation. And because of that, they can suffer from bladder issues. So that's one thing that you really, like Dr. Steady says, you really have to exclude when you are seeing these kids and treat. And sometimes treating the constipation can resolve the bladder issues as well. Thank you.
Great. Thank you. I see Dr. Jewel is here. I don't know if he has any comments or any questions.
Thank you, Charles. I just arrived, sorry. I was in another meeting, so I don't have any questions or comments.
All right. Thank you, Doc. I think from the looks of it, we do not have any other comments or questions. So I think at this juncture, I'd like to send a very heartfelt, deep appreciation for our good doctor, our pediatric nephrologist, Dr. Mosalakatani, for this brilliant presentation. And I don't know if she has any last words she'd like to share before we, I see my boss, Dr. Mulu, he wants to make a comment. Over to you, sir.
Hello, Doc. Thank you very much. I was hoping to comment after you finish talking, but just as a thank you talking to BDU for organizing this type of talks, because I think one of the biggest problems that I see in our country is that medicine is too fragmented, and most of us trained at school, and then that was the last time we actually had a proper revision of the things that have evolved in the world of medicine over time. So I think having talks like this helps to bring to surface the things that most of us may have forgotten about these pertinent issues. Because I don't think this issue that Dr. Mosalakatani talked about are straightforward. It applies to other specialties. But I think since we are commenting that we actually have improvement in the availability of specialized services, it's important that actually now they become more prominent in terms of discussing this condition that they manage, so that we know when to refer. Because the biggest problem is we see a lot of cases that are being presented. These are cases that most of which come very late, and then they come from a very select few. There'll be people who are known to refer cases. They pick them early, they refer, and we'll be like they're all in Maung. But we realize that actually they're in Hunt, they are everywhere else. Unfortunately, then those who happen to not be in Maung tend to be missed. So it's very, very important that we actually discuss this. And we have this platform by BDU to actually keep on spreading this important message. Some of these things, for some of us, are very new. So we thank Dr. Mosalakatani for enlightening us and teaching us about these conditions in children. Thank you.
Thank you so much, sir. I think you said it all. I don't know, Tembi, is there anything you'd like to react to? Is there any last closing words that you'd like to say to the audience?
No, not much. I think I've said everything, and just to keep on encouraging the doctors there to continue what they are doing, and also to just go into the subspecialty field so that we can really improve the care of our patients. Thank you.
Okay, no, thank you so much for that. So thank you everyone for being present today. This session was recorded, and the link will be shared on the usual group. So you'll be able to, for those who joined late, for example, Dr. Jewel, you'll be able to view this at your leisure We will have another session next week, Wednesday. The exact presentation will be communicated soon. Let's continue to work together. And I'd like to encourage those who are not part of BDU to become part of BDU. So thank you, everyone, and good night.
Bye. Bye, everyone.